Yeah, we're just gonna give them all to
John.
John. Let's hope so.
I hope so.
Are we gonna be like introduced or do I just?
I'm gonna put one of these away.
Yeah, thanks.
Just drop it there.
Hello, everybody, and welcome to Grand Rounds. Today, hello. If you're watching at home, these are our first-year medical students who we're changing it up a little bit today. The first group is actually going to give us an overview of Myasthenia Gravis, and then the second group will give us a case presentation. If you're wondering why I'm so casually dressed today, I'm in support of the Royals in their last game against the Astros tonight, and the rest of the faculty and staff and whole university is participating as well. So here is Myasthenia Gravis.
All right. Can everybody hear me? Good. Thanks, Dr. McGowan. Thank you to our faculty and professors, everyone for coming out, and everyone watching online. Thank you. And so we'll begin. We are Group 5, and we will be presenting and discussing Myasthenia Gravis. These are our members, all of whom are up here next to me. So I am student Dr. Asim Chaudhry. I'll be presenting the physiology, pathology, and epidemiology of Myasthenia Gravis. My section will be followed by a discussion on the differentials, and we'll conclude with the treatments, and then open up for questions. So what is Myasthenia Gravis? Myasthenia Gravis is an autoimmune disorder that's characterized by the production of autoantibodies that will attack the neuromuscular junction, and the net result of this is that you will not have muscle contraction. The antibodies produced specifically will target nicotinic acetylcholine receptors and or the muscle-specific kinase protein, or MuSK protein. So where are these antibodies produced? Well, they're produced by the thymus. And interestingly, in 60 to 70% of cases or patients with myasthenia gravis, they will also be diagnosed with thymic hyperplasia. And in 10 to 15% of cases of myasthenia gravis, those patients will be diagnosed with a thymoma. So I think the thymic hyperplasia and thymoma kind of agree with, or they may be contributing factors to why the thymus produces these autoantibodies. So in order to understand the pathology of myasthenia gravis, we have to understand how a normal neuromuscular junction works. So I'll recap that really quickly. So you have an action potential that will come in, and it reaches the terminal end of the nerve. It will cause the influx of calcium ions by activating these voltage-gated calcium channels. So calcium will rush into the cell, which will cause these vesicles here that contain the neurotransmitter acetylcholine to be exocytosed. So this process of vesicle release is aided by this protein called synaptotagmin. So acetylcholine is released into the synaptic cleft. It'll travel across, and it will bind to these acetylcholine receptors, the nicotinic acetylcholine receptors. So once it binds, it causes an local potential. And if that local potential is strong enough, it's going to cause an action potential, which will ultimately result in muscle contraction. Another important part of the neuromuscular junction is this protein here. This is called MuSK, or muscle-specific kinase. And what MuSK does is that upon its activation, it will send signals and recruit scaffolding proteins, such as rhabsin. And together, these will cause the aggregation of these acetylcholine receptors. And you want to have aggregation of these acetylcholine receptors because it makes it easier for the acetylcholine molecules to find and bind to these receptors, causing activation. Another important aspect of the neuromuscular junction is this enzyme here. This is called acetylcholinesterase. And what acetylcholinesterase does is it will bind to these acetylcholine molecules, and it will break them down and send them back to be recycled. So why do you want to break down acetylcholine molecules? Because so long as acetylcholine is bound to its receptor on the postsynaptic membrane, it will cause muscle activation or stimulation. So you don't want to have constant activation or stimulation of the muscles. So in order to regulate that process, acetylcholinesterase is going to break down acetylcholine. So what goes wrong in myasthenia gravis? As I mentioned earlier, the thymus produces autoantibodies that will target acetylcholine receptors and the musk protein. So that's what's going to happen is antibodies will be released, and they'll come down and bind to these nicotinic acetylcholine receptors. And there's 3 different ways or mechanisms by which the antibodies will inhibit the receptor, and I'll discuss that in the next slide. Or you can have antibodies produced against the musk protein, which is right here. And again, if you inhibit musk, you no longer have the aggregation of these acetylcholine receptors, which makes it difficult for acetylcholine to find and bind to the receptors, causing muscle contraction. So that process will become difficult if musk is inactivated. So this figure is, well, it's really 3 figures, A, B, and C. These are the 3 mechanisms by which the antibodies will inhibit the acetylcholine receptor. So in the top figure, figure A, you have the antibodies come and they will bind to acetylcholine receptors here and here. And this will cause the activation of the complement cascade. So complement is activated, and that will really, lead to the formation of the MAC, or membrane attack complex. And the MAC will do what it sounds like it does. It will attack the membrane and destroy the morphology of the muscle membrane. So you will no longer have the ability to complete the signaling process. The second way in which the antibodies will inhibit acetylcholine receptor is that they will cross-link to the receptors. So antibody will come in, it will bind to 2 different acetylcholine receptors, and these will subsequently be internalized and then destroyed. And again, you cannot have signaling if the receptors are destroyed. And the third way, perhaps the simplest mechanism by which the inhibition of acetylcholine receptors happens, is that the anti-nicotinic acetylcholine receptor antibodies will come and they will bind to the acetylcholine receptor, simply blocking the binding site. So acetylcholine can't bind if something is already there, and that doesn't allow for muscle contraction. So the net effect of all 3 of these processes is the same. Muscle contraction will not occur. So there's different types of myasthenia gravis. They can be classified as ocular, generalized congenital, or transient neonatal, and I'll discuss these in a little more detail in the following slides. Each of these different types can be differentiated based on several factors, which include the age of onset, and it can be differentiated based on which autoantibodies are produced. So is the type of antibody going to be the anti-musk antibody, or will it be the anti-acetylcholine receptor antibody? And further, you can differentiate these based on the muscles that are affected. So the first type and the most common type of myasthenia gravis is ocular myasthenia gravis. And as is indicated by the name, it's the ocular muscles that are affected. This type of myasthenia gravis produces both antibodies to either the acetylcholine receptor, or it can produce the antibodies to the musk protein. And in 15% of cases of myasthenia gravis, it's only the ocular muscles that are affected. The next kind is generalized myasthenia gravis, which can be further broken down into different subtypes, 4 subtypes. And these are differentiated based on the age of onset. So the first type is neonatal generalized myasthenia gravis. And this will be diagnosed in patients between birth and the age of 2. So 0 to 2 will be considered neonatal myasthenia gravis. Juvenile myasthenia gravis is between the ages of 2 and 20. Early onset myasthenia gravis is between the ages of 20 and 40. And interesting thing about early onset is that it's more commonly diagnosed in females as compared to late onset, which is more commonly diagnosed in males. And late onset is going to be characterized if you are older than 40. And yeah, again, it's more common in males. And generalized myasthenia gravis can also produce either autoantibody to the musk protein or to the anti-acetylcholine receptor. Congenital myasthenia gravis, this is an interesting kind of myasthenia gravis because its pathology is slightly different than the other forms of myasthenia gravis. So rather than having autoantibodies produced by the thymus, you actually have a defect in the nicotinic acetylcholine receptor itself. So no antibodies are produced, but you're born with a mutation in the receptor, in the acetylcholine receptor, which the effect is essentially the same. You can't have signaling, and muscle contraction is weakened. This manifests shortly after birth, and it can affect the ocular or bulbar muscles. Transient neonatal myasthenia gravis, this is also interesting, and its pathology is slightly different as well. You do have antibodies produced that will target the acetylcholine receptor. However, they're not produced by the fetus itself. This is in cases where the mother has myasthenia gravis, and the mother's antibodies will travel across the placenta and attack the acetylcholine receptors in the fetus. And this presents in 10 to 15% of infants whose mothers have myasthenia gravis. And another interesting thing about transient neonatal myasthenia gravis is if the mother has myasthenia gravis and she has a child who is diagnosed with transient neonatal myasthenia gravis, there's a 75% chance that in subsequent pregnancies, those fetuses will also have transient neonatal myasthenia gravis. And this usually presents within a few hours of birth. However, if it is recognized early, diagnosed, and treatment is started, the baby will usually recover within a few weeks. Myasthenia gravis crisis. This is a very important aspect of myasthenia gravis. And what myasthenia gravis crisis is a life-threatening complication of the disease. And so normally you have antibodies to the acetylcholine receptor, which causes muscle weakness. Same thing happens in myasthenia gravis crisis, except you're targeting the respiratory muscles. So if you can't use your respiratory muscles, then you can't breathe. And that is a serious complication. And we'll talk about the treatments of this in the last section. The symptoms are dyspnea and dysphagia. And 10 to 20% of myasthenia gravis patients will experience this at least once in their life. And another interesting aspect, and why this crisis can also be so scary, is because in 10 to 15% of cases, myasthenia gravis crisis is the first presentation or manifestation of myasthenia gravis. So they don't know they have it until they undergo this crisis. Some of the precipitating factors or things that can increase an individual's likelihood of entering myasthenia gravis include if it can be in pregnant women, they are at a higher risk. If you are post-surgery and you have myasthenia gravis, you can be at a higher risk of undergoing myasthenia crisis. And the most common inducer of myasthenia gravis crisis is a bacterial-induced pneumonia. And additionally, certain drugs can cause you to be at a greater risk. For example, certain antibiotics or cardiac drugs such as beta blockers. So finally, I'll talk about some of the epidemiology of myasthenia gravis. So hopefully you can get a better perspective of the disease. So females that are diagnosed are mainly between the ages of 20 and 30. And again, that would be characterized as early onset generalized myasthenia gravis. Males are more likely to be diagnosed between the ages of 60 and 80. And that again is characterized as late onset generalized myasthenia gravis. There are 7 to 9 new cases per 1 million globally, and the prevalence is about 70 to 165 per 1 million globally. And childhood cases are less common in Europe and North America as compared to Asia. And that concludes the first portion of our presentation. I will pass the floor to my colleague, student Dr. Ryan Carnegie, to discuss the differentials.
Thank you, student Dr. Chaudhry. I will be presenting upon the differential diagnoses and clinical tests associated with diagnosis of myasthenia gravis. In our normal neuromuscular junction, as the physiology was previously described, myasthenia is going to interrupt the normal mechanisms of this neuromuscular junction by autoimmune attack of the nicotinic acetylcholine receptor, or the MuSK protein, which aggregates the nicotinic acetylcholine receptor. Autoimmunity to these receptors are going to involve 3 different pathways. one of which will trigger the complement pathway, which will result in the destruction of the postsynaptic end plate membrane. Alternatively, we could simply block the active site of the nicotinic acetylcholine receptor, or we can cross-link multiple receptors, which will lead to internalization and degradation of the acetylcholine receptor. So presenting symptoms of myasthenia gravis may typically include ptosis, diplopia, dysarthria, dysphagia, muscle weakness, and fatigability. While there are documented studies of other symptoms, these are going to be the most common. So when we consider symptoms such as generalized or ocular muscle weakness, we have to consider what other diseases may deter us from diagnosing myasthenia gravis. Among these include Horner syndrome, Lambert-Eaton myasthenic syndrome, botulism, and multiple sclerosis, as well as Guillain-Barré syndrome with Miller-Fisher variant of Guillain-Barré syndrome. So starting with myasthenia gravis itself, there are 2 bedside tests that we might consider before sending any samples off to the lab. Among these are the ice pack test and the edrophonium test. The ice pack test, as it sounds, is just the simple administration of an ice pack to the affected area. Due to the fact that acetylcholine esterase is degrading acetylcholine in the neuromuscular junction, ice pack administration will attenuate this rate of degradation due to the temperature-dependent timescale of degradation of acetylcholine esterase. So in this case, we have a patient with bilateral ptosis, or weakening of the extraocular muscles. After the administration of the ice pack, we see marked improvement bilaterally. Alternatively, also dealing with that acetylcholine esterase, we have the edrophonium test. While edrophonium is the drug used to chemically inhibit acetylcholine esterase, Tensilon is a brand name by which some of us might recognize. So while there is no difference in these 2 terms, they're both going to be dealing with chemical inhibition of acetylcholine esterase. Something to consider when remembering the historical impact of the edrophonium test is that it's used to treat myasthenia gravis to increase the acetylcholine in the neuromuscular junction. This increase of acetylcholine will competitively displace those antibodies and allow some stimulation of the muscle. However, alternatively, we have a cholinergic crisis, which is going to deal with an excess of acetylcholine in the neuromuscular junction, and both of these are going to present with similar symptoms. Therefore, until we are confident in our diagnosis of myasthenia gravis, we must use precaution when considering something that may exacerbate symptoms of a cholinergic crisis. Returning to our diagram of myasthenia gravis, we have to consider where these antibodies come from. And as previously mentioned, we have heavy implications of a neoplastic thymus in the pathology of this disease. Now, as we know, in the thymus, we have naive T cells, which are going to have various antigens presented to them. If the T cells are determined to have autoimmune responses, they are normally negatively selected for survival. However, in a dysfunctional thymus, such as in a thymoma, we're going to have positive selection of antigens for nicotinic acetylcholine receptor, or alternatively for the MuSK protein. And as you can see by this reciprocal relationship between myasthenia gravis patients and thymoma patients, there are heavy implications in a neoplastic thymus for the diagnosis of myasthenia gravis. Therefore, when we diagnose myasthenia gravis, we should immediately proceed to diagnose whether or not the patient has a thymoma. Diagnoses of these can be procured by the physical examination of the patient, a biopsy of the thymus, as well as radiographic imaging such as a CT. On the left, we have a normal thymus, and on the right, with the arrow pointing to a neoplastic thymus in the terms of a thymoma. Moving on to our first differential, we have Horner syndrome, which is going to involve a lesion in the sympathetic nervous system supplying the head and neck. Symptoms of this might relate to myasthenia gravis, such as the symptom of ptosis. Other symptoms that might help us to distinguish Horner syndrome from myasthenia gravis are going to deal with anisocoria, or a difference in the size of the pupils of the patient between left and right pupil. Cocaine administration for a normal patient is going to involve the dilation of a patient's pupil. However, in Horner syndrome, with its lesion affecting the head and neck, we're not going to see that dilation of pupils. Therefore, we can distinguish a Horner syndrome-stricken patient from a myasthenia gravis patient. Moving on to our next differential, we have Lambert-Eaton myasthenic syndrome, which is going to be our largest differential when considering myasthenia gravis due to the high interrelatability of the two diseases. Lambert-Eaton myasthenic syndrome is also going to affect the neuromuscular junction, however, a few steps earlier affecting the voltage-gated calcium channel in terms of autoimmunity. Relatable symptoms might also include muscular weakness, which is going to provide the reason for why it is such a large differential. However, it can be distinguished in the context of single fiber electromyography, which is going to involve the probe-based stimulation of a neuron supplying 2 or more muscle fibers, and the jitter between those fibers are going to distinguish a myasthenia gravis patient from an alternative patient with a sensitivity greater than 95%. Additionally, radioimmunoassay we can use to test for these various antibodies, such as antibodies to nicotinic acetylcholine receptor, MuSK protein, and the voltage-gated calcium channel, which will assist us in distinguishing these two diseases. Lambert-Eaton myasthenic syndrome also has a heavy implication for cancer, and in this case, 50% of patients presenting with Lambert-Eaton myasthenic syndrome are also studied to have small cell lung cancer. Botulism is going to involve a toxin known as botulinum, which is going to irreversibly disable the synaptotagmin protein responsible for the efflux of vesicles containing acetylcholine neurotransmitters into the neuromuscular junction. Other symptoms might help distinguish, however, our hallmark test when regarding botulism is going to be a Western blot for the botulinum toxin. Oops. Other toxins we might want to consider in the diagnosis of myasthenia gravis are going to regard organophosphorus esters and triorthocresyl phosphate. Organophosphorus esters are going to be found in common household products such as insecticides, while triorthocresyl phosphate might be found in plastic softener, has been found in cooking oil historically, and might also be found in things such as laundry detergent. These are both going to affect the neuromuscular junction or the axons itself, involving relatable symptoms to myasthenia gravis. They might also increase the amount of acetylcholine in the neuromuscular junction, leading to a cholinergic crisis. However, due to the fact that myasthenia gravis affects the nicotinic acetylcholine receptors and is largely implicated in skeletal muscle transduction of contraction, these other toxins might globally affect acetylcholine in other junctions, in which case we might have such symptoms as bradycardia and pulmonary edema. Moving on to our final three differentials in this brief differential diagnostic study. We're going to consider 3 differentials that deal with the demyelination of the neuromuscular junction. Multiple sclerosis, Guillain-Barré syndrome, and Miller-Fisher syndrome are all going to be involved in this process and can be distinguished by the following. While multiple sclerosis' mechanism is poorly understood, we do accept as a medical community that it involves the demyelination of axons, and the diagnosis of it is going to be determined by clinical confirmation of various symptoms listed here, as well as an MRI in both time and space confirming the lesions attacking the axons. Guillain-Barré syndrome also deals with a progressive muscular weakness. However, clinical confirmation of it will be distinguished from multiple sclerosis by such aspects as areflexia. Also, cerebrospinal fluid will be studied in the terms of Guillain-Barré syndrome to test for albuminocytologic dissociation, which is the increase in protein of the cerebrospinal fluid while maintaining a normal white blood cell count. Miller-Fisher syndrome is going to be a variant of Guillain-Barré syndrome. However, it may be distinguished from Guillain-Barré syndrome in the terms of ophthalmoplegia, ataxia, and most importantly by an autoimmune antibody to ganglioside Q1b found at the polar extremes of a myelin sheath. With these various differentials considered, we're going to move on to considerations of treatment and management of myasthenic patients. Thank you.
Thank you very much, student Dr. Carnegie. I'm student Dr. Stephen Carl, and I'm going to discuss the current and future treatment strategies as well as some management strategies when considering patients with myasthenia gravis. So the conventional treatment plan for myasthenia gravis is based upon these 4 options: acetylcholinesterase inhibition, corticosteroid treatment, immunosuppression, and surgical thymectomy. Each of these therapies takes a different amount of time to elicit symptom improvement, and each patient is going to require a different and individualized treatment plan. These plans require periodic adjustment of the various components throughout the disease, and the standard of treatment has largely been based upon serendipity and retrospective analyses, as well as institutional preference and physician preference. It's been largely established despite a lack of controlled study. And having said that, using the current treatment spectrum, using the spectrum of current treatment options, most myasthenia gravis patients live largely normal lives and have good prognoses in terms of both survival and quality of life. So acetylcholinesterase inhibition is the first-line treatment for patients with myasthenia gravis. Inhibiting the enzymatic breakdown of acetylcholine within the neuromuscular junction is going to allow us to saturate the remaining functional receptors and thus increase the rate at which acetylcholine binds to and causes subsequent action potential firing and muscle contraction. Predostigmine has been the gold standard acetylcholinesterase inhibitor in the treatment of myasthenia gravis for about the past 60 years. Immunomodulation therapy has been carried out in tandem throughout the course of myasthenia gravis treatment. So both steroid and steroid-sparing agents are going to be utilized as long-term immunosuppressants. The most widely utilized steroid-sparing agent is azathioprine. However, methotrexate is a commonly utilized alternative. Corticosteroids such as prednisone are often needed and need to be tapered up and down as symptoms flare up throughout the disease progression and course of a myasthenic patient's life. However, these steroid treatments are not preferred due to their commonly elicited side effects. That being said, even patient with well-controlled myasthenia gravis through use of things such as azathioprine and acetylcholinesterase inhibition will still require brief steroid treatment, especially during times of infection or surgery. The administration of rapid immunotherapies is also occasionally required during the course of a myasthenia gravis treatment. These rapid treatments, such as plasmapheresis and intravenous administration of immunoglobulins, are occasionally necessary to address acute exacerbations, such as the aforementioned described myasthenic crisis. As my colleagues have discussed, thymus is highly implicated in the development and onset of myasthenia gravis. Given its minimal function in adults, is recommended as a prophylactic treatment to undergo surgical thymectomy, regardless of whether or not there's a concurrent thymoma present. This, however, has been seen to be contraindicated for individuals simply with antibodies to the musk protein. There are also certain treatments to look to avoid while putting together a therapeutic plan for a myasthenia gravis patient. These include anything that's going to exacerbate the muscle weakness seen with the disease by inhibiting activity at the neuromuscular junction. This is done through neuromuscular blocking agents such as beta blockers or aminoglycosides. Also, anything that may put a patient at risk of, or will diminish the respiratory function and thus put a patient at risk for myasthenic crisis, such as benzodiazepines or narcotics and certain sedatives, would be contraindicated. Concerning the future treatment plans or future treatment options for patients with myasthenia gravis, most emerging therapeutic options have been focused on replacing steroid treatments and finding more rapid and targeted immunotherapies. In general, these drugs have targeted components of humoral autoimmune responses through things such as proteasome inhibition or downregulation of transcription factors, and thus a diminished production of autoreactive B cells. Several of these different drugs have shown promising results and encouraging results over the past few years in small clinical trials. As far as osteopathic manipulative treatments go, any indirect treatments targeting lymphatics or myofascial release may be helpful. However, as with any other osteopathic manipulative treatment, it is very important to take into account a patient's pain tolerance when performing or considering any of these treatments. There are numerous pamphlets that can be disseminated to both patients and their families to help educate them on the process of myasthenia gravis throughout their lives. These pamphlets are available through sources such as Up to Date, as well as the Myasthenia Gravis Association of Missouri and Kansas. Locally, the MG Association of Kansas and Missouri also provides a variety of services in addition to these educational resources, which include social services referrals or a list of neurologists who specialize in the treatment of myasthenia gravis. Given my statements regarding the individualized nature of these treatment plans, as well as the aforementioned bilateral distribution of the disease onset, ethical corollaries associated with the treatment of MG involve the patient education and long-term planning processes. The process of constructing an advanced directive requires the development of an individualized treatment plan and individualized plan as far as therapeutics and other factors of their life. It's critical to communicate to the patient the side effects and potential dependence and tolerance they feel with the common treatment plans, and also important to take into account a patient's age, gender, and lifestyle. For instance, a younger woman with early onset MG, it may make sense to discuss family planning and pregnancy planning, whereas in an older onset patient, things like establishing power of attorney may take a priority. With that being said, I'd like to thank the following, on behalf of my group, I would like to thank the following faculty members at KCU and open this up for questions. Thank you very much. Go Royals.
That was a great overview, you guys. You can tell you worked very hard on this. Let's go ahead, and I know that we have several questions, so which side wants to go first? Ready?
So the first question we received was, what are the signs and symptoms of a cholinergic overdose or crisis? And a cholinergic crisis is caused by an excess of acetylcholine in the neuromuscular junction, and it presents as focal or generalized muscle weakness, respiratory difficulty or failure, and bronchospasms, as well as bronchorrhea.
So we received a question on the onset of generalized myasthenia gravis, why there's a certain onset at certain ages, and why the early onset is more frequent in females and the late onset is more common in males. And there is actually no clear reason yet for this.
Okay, our third question was, how do you differentiate myasthenia gravis from ALS? Both are neuromuscular diseases. So ALS is amyotrophic lateral sclerosis. It's a progressive disease which, like myasthenia, also involves the bulbar muscles, and it leads to facial weakness, dysarthria, and dysphagia, which Ryan described in our presentation. But the difference that you can tell clinically is that in myasthenia gravis, you have that ptosis and ocular dysmotility, which causes a double vision. You don't typically see those in ALS. And also you will have, in myasthenia gravis, there's hyperreflexia, but then in ALS, you get that as well as atrophy and fasciculations of the muscles.
All right, so another question we had was, which bacteria induces the myasthenia gravis crisis? And so as we mentioned, it's a bacterial-induced pneumonia that can be a precipitating factor for myasthenia or myasthenic crisis. And there's a lot of different bacteria that can do this. So just to list a few, we had Streptococcus pneumonia, Mycoplasma pneumonia, Chlamydia pneumonia, and Haemophilus influenza. And really fast, just another question that we had that was kind of answered in our presentation, but is there a difference between the tensilon test and the edrophonium test? So the tensilon test and the edrophonium test are the same test. Just tensilon is the brand name for the drug used during the test.
Our next question was, are certain ocular muscles affected by myasthenia gravis more than other ocular muscles? The most commonly involved extraocular muscle is the medial rectus. The medial rectus is the largest of the eye's extraocular movement muscles, and it is one of 6 individual muscles that surround the eye and help control movement.
We received a question about what are bulbar muscles, and these are the muscles of the mouth and jaw and other muscles relating to swallowing, chewing, eating, or speech. And they're called bulbar muscles because they're innervated by the medulla oblongata, which is the archaic term for medulla oblongata is the bulb. And another question that we received was, what is progressive bulbar palsy? And it's a progressive upper and lower motor neuron disorder of cranial muscles. And this condition may occasionally stay isolated towards the bulbar segment, but more commonly it migrates to other segments, and which would be called bulbar onset ALS.
And the last question we received was, what defect causes the congenital version of myasthenic gravis? And it's defects in presynaptic, synaptic basal lamina, and postsynaptic components of the neuromuscular junction, specifically affecting the proteins of DOX7, rhapsin, and DPAGT1. And DOX7 and rhapsin were also talked about previously in the presentation.
Okay. Are there any comments?
I think you guys did a great job. Congratulations. We have a ALS expert with us here, but I wonder if Dr. Zhao, do you have any comments on presentation? I'm going to pass the microphone to you.
Yeah, I do have questions, but that's a very wonderful presentation. I learned a lot also. Okay, actually, I don't think my question was answered. Yeah, for ALS, I think the diagnosis, basically you have to exclude other disease, and then you have the last diagnosis will be ALS, right? So I will not have more comment on that. I think they already did a very good job. And actually, I have 2 questions, right? And why you think the beta blocker, when you have the MG and the beta blocker will exacerbate the syndrome of the MG? When you have these, when you have the treatment and then you have these other medication there, why beta blocker will be cannot be used and will. Okay. Oh really? Oh, I was okay. I'm sorry. I probably I was good. Okay. I don't know. Yeah, I don't know. I don't know.
blocker that antagonizes the epinephrine contribution to respiratory muscle tone, then you'll get excess constriction, insufficient relaxation. So that's my explanation.
Any further comments, Dr. Zhao? Why are the ocular muscles affected?
So in the extraocular region, we have a lower amount of regulation of the complement system. And due to that fact, as we mentioned, one of the three mechanisms by which we affect the neuromuscular junction is going to be complement-mediated degradation of the end plate membrane of the muscle. So with the lower regulation of that complement-mediated degradation, we're going to see a higher frequency of muscular weakness in the ocular region.
Again, you guys did a great job, and I've got to mention one thing for those people who are viewing you is that you guys haven't studied any of this formally in class. This is all self-taught and part of the course of medical informatics. So congratulations on the world of lifelong learning, and thank you very much for a great presentation.
All right, time to switch to our next presenters, which have a case for us.
Okay, let's get started. Good afternoon, and thank you for attending our presentation today. Thank you to those of you who are watching online. We are group number 6, presenting case number 7 from the case records of the Massachusetts General Hospital from the year 2012. The title of our case is a 79-year-old man with pain and weakness in the legs. Here is a list of the members of group number 6 along with our photo. I'm student Dr. Brittany Dolliger, and I will be discussing the patient history and the clinical presentation. The chief complaint of our patient was muscle pain and weakness in the legs. A 79-year-old non-English speaking, illiterate Hispanic male presented to the Massachusetts General Hospital with complaints of pain and weakness in the legs. The onset of his symptoms occurred 6 days prior to his arrival. The patient experienced no relief with rest, as opposed to previously, when rest would alleviate his symptoms of pain due to his intermittent claudication. Nothing aggravated the pain or weakness. However, it progressively worsened over the course of the 6 days. The pain and weakness was constant, and the pain was generalized in the lower extremities. The patient also had no history of trauma, falls, contact with a sick person, or any recent travel. As I mentioned previously, our timeline begins 6 days prior to admission when the onset of the symptoms occurred. It began with progressive generalized pain and tingling in both legs. 3 days prior to admission, weakness began to develop in both legs, and it gradually worsened. Our patient began to have difficulty walking. On the day of admission, our patient had become so weak that he was unable to get out of bed, which prompted his wife to call 911, and he was transported by EMS to the emergency department. Our patient had a plethora of chronic conditions. The following is a list of his past medical history, including the past 10 and the past 6 years. Within the past 6 years, our patient developed worsening chronic kidney disease, and he was in stage 3 of 5, which is defined as a moderate kidney disease with a glomerular filtration rate of 30 to 59. As a result of his many chronic conditions, the patient was prescribed the following medications for the various conditions shown. It's also important to note here that our patient was known to have a history of non-adherence with his medications. However, more recent to his hospital stay, he had become more adherent due to a visiting nurse giving him his medications and the pharmacy pre-packaging his medications. He also had no known drug allergies. His past surgical history includes a benign colonic adenoma found on his routine colonoscopy and a transurethral prosthetic resection performed for his BPH, both of those 3 years prior. 8 days prior to his admission, he had an esophagogastroduodenoscopy performed in which his physicians were looking for the cause of what they thought to be an iron-deficient anemia. They found non-bleeding ulcers. His social history includes that he was a past smoker, he moderately drank alcohol, he was not on any illicit drugs, and he had a possible exposure to cleaning solvents from a previous service position. Upon his arrival to the emergency department, his vitals were taken, and they were as follows. His temperature was 37 degrees Celsius, his blood pressure was 150/72, his pulse was 86 beats per minute, his respirations were 20 breaths per minute, and his oxygen saturation was 99%. He had decreased reflexes, and his plantar reflexes were equivocal, which means that the physicians were unable to determine whether they were normal or abnormal. The strength of his arms and legs were evaluated, and the strength of his legs were on the left leg 3 out of 5 and 2 out of 5 on his right leg. His arm strength was normal with a value of 5 out of 5. His gait was unable to assess due to his weakness, and his emotional state was noted as anxious and teary-eyed. Upon his arrival, the patient also had many diagnostic labs taken. It's important to keep in mind that the patient was suffering from an acute condition on top of his many chronic conditions. And as you will see shortly, this could be a cause as to why the patient had so many abnormal lab values. I also want to mention here that the lab values that are important to the patient's final diagnosis will be discussed in further detail in the differential. The results of his urinalysis were an albumin of 2+, blood of 3+, red blood cells and lymphocytes of 0 to 2, elevated hyaline Cas of 3 to 5, elevated granular Cas of 10 to 20, few renal tubule cells, and he had amorphous crystals and mucin in the urine. Ultimately, his urinalysis demonstrated that our patient was suffering from chronic kidney disease. A CBC was also taken. He had a decreased hematocrit with a value of 25.7. He had decreased hemoglobin with a value of 8.4. His white blood cells and neutrophils were elevated above the normal range with values of 13,700 and 86 respectively. His red cell distribution width was also elevated above the normal range with a value of 16.1. His chemistry panel had many abnormal lab values. His glucose was 117, elevated above the normal range. His urea nitrogen was 83, elevated above the normal range. His creatinine was 4.13, also elevated above the normal range, compared to 2.78 9 months prior. He had increased potassium with a value of 6.3, compared to 4.6 9 months prior. He had decreased carbon dioxide with a value of 18. His glomerular filtration rate had gone down to 15. He had elevated phosphorus with a level of with a value of 5, increased magnesium with a value of 1.3. Both of his AST and ALT were elevated. He had an AST of 698, well above the normal range, compared to 13 3 months prior. His ALT was elevated and was at a value of 204, also well above the normal range, compared to 11 3 months prior. The following miscellaneous diagnostic labs were taken. His erythrocyte sedimentation rate was 117. His C-reactive protein was 48.6. His uric acid was 9.5. His D-dimer was 1,197. And his fibrinogen was 656. All of those values were elevated above the normal range. His venous pH was 7.34, which is on the low end of the normal range. His creatine kinase was elevated well above the normal range with a value of 37,479. His creatine kinase myocardial B fraction was elevated with a value of 94.2, and his troponin T was elevated with a value of 0.22. He also had an electrocardiogram performed, and the results were normal. On his first day in the hospital, the patient's physicians discontinued his lisinopril, simvastatin, and gemfibrozil, all drugs known to cause myopathy. They also discontinued his simvastatin due to his high AST and ALT lab values. His other medications were continued. He was given Kayexalate, insulin, dextrose, and furosemide in order to drive his levels of potassium down. He was given intravenous crystalloid to help with his dehydration, and he was given bicarbonate for his non-anion gap metabolic acidosis. On hospital days 2 through 7, heparin and epoetin alpha were administered, intravenous furosemide, and fluids. His leg strength decreased to 1 to 2 out of 5, compared to 2 to 3 out of 5 when he first arrived. His arm strength decreased from 5 out of 5 to 3 out of 5. His muscle tenderness and weakness persisted. He also developed diffuse abdominal distension, for which a CAT scan of the abdomen and pelvis were performed, and a nasogastric and rectal tube were placed to alleviate those symptoms. On hospital days 2 through 7, the following diagnostic tests were performed. The tests that were important to the patient's final diagnosis will also be discussed in further detail in the differential. On hospital day 8, a diagnostic muscle biopsy was performed, which leads me to introduce my colleague, student Dr. Jordan Damshin.
Thank you, student Dr. Brittany Gallagher. I am student Dr. Jordan Damshin, and I will be presenting the differential diagnosis for our case. There can be many causes of generalized weakness. Given the normal health of our patient 6 days prior to admission, with no history of falls or trauma, osteomalacia, herniated disc, and other structural dysfunctions are unlikely causes of our patient's acute weakness. With no fever and only mildly elevated white blood cell counts, occult infection resulting in secondary muscle weakness is also unlikely. Normal thyrotroponin levels help to eliminate a hyperthyroid-induced muscle weakness. Diabetic muscle infarction can be characterized by acute weakness in the lower extremities, which typically does not progress to the upper limbs. The quick progression of our patient's symptoms into the upper arms helps to eliminate this as well. While our patient does have anemia, and anemia can induce generalized weakness, his anemia is due to chronic kidney failure and does not describe the acute symptoms he's experiencing. Rheumatological disorders can induce muscle weakness and myalgia. They're also characterized by a loss of joint mobility as well as muscle atrophy. Again, these are chronic symptoms and don't sufficiently explain the acute symptoms he's experiencing. Damage to the central nervous system would be accompanied by a loss of cranial nerve function, a loss of balance, a loss of bowel and bladder control, as well as a loss of consciousness, none of which our patient experienced. There can be many damages within the peripheral nervous system, and we will use the physical, sensory, and reflex exams to begin to eliminate possible causes. When looking at the physical exam, we want to think about patterns of weakness. Is it unilateral or bilateral? Is it proximal or distal? Is it segmental or task specific? Our patient had bilateral weakness in the legs that progressed to both arms and was proximal and distal. His sensory exam was deemed normal, and his reflex exam was also deemed normal. Guillain-Barré syndrome, porphyrias, and other neuropathic conditions can be ruled out given the normal sensory and reflex exam. Moving on to the laboratory data, the most significant finding is his creatine kinase levels, over 100 times greater than the reference range. We would not expect to see elevated creatine kinase with a neuromuscular junction disorder, and motor neuron disorders are typically no more than 10 times elevated. We should also note that creatine kinase is a dimer molecule and comes in three forms: MM, which is predominantly skeletal muscle, MB, predominantly cardiac muscle, and BB, which can be found in the brain and in the liver and is of no importance for our case. Creatine kinase MB can be indicative of myocardial infarction. However, troponin I is a more specific marker as it is not found in skeletal muscle. With no report of troponin I levels, along with elevated troponin T and elevated creatine kinase MB, both of which can be found in skeletal muscle, these results indicate inflamed and regenerative skeletal muscle likely due to myopathy. Elevated ALT and AST are most often associated with liver disease. Given the presentation of our patient and the concurrent medications he was taking, these are likely statin-induced. We should also note the negative testing for hepatitis B and hepatitis C, meaning that these elevated values could also be indicative of muscle damage. The elevated anti-Rho, along with a positive serological test for anti-nuclear antibody, can be indicative of an autoimmune reaction, which will require a muscle biopsy to confirm or deny. Together, these results suggest a myopathic process, and we performed electrode diagnostic studies. The first part is the nerve conduction study, where an electrode is placed on a target nerve of interest in both the leg and the arm. A stimulatory electrode at a known distance away applies a shock, and the activity at the neuromuscular junction is recorded. This was deemed normal. A normal nerve conduction study, along with elevated creatine kinase, eliminates myasthenia gravis, Lambert Eaton myasthenic syndrome, as well as other neuromuscular junction disorders. The second part of our study is electromyography, where a fine sterile needle is placed within the target muscle, and the patient is asked to relax and mildly contract while electrical activity is recorded. To understand these recordings, we must first think about the motor unit action potential. A muscle is composed of many fibers. Within those fibers are many fibrils. Within those fibrils are many filaments composing the contractile unit. An action potential will move from the motor neuron down the axon to the neuromuscular junction, where it generates a motor unit action potential. The electrode can recognize this motor unit action potential as it approaches, contacts, and dissipates away from the electrode, resulting in a triphasic oscillatory pattern, as we see here. In a myopathic process, the muscle fibers are necrosed and damaged, resulting in a decreased ability to generate and maintain this motor unit action potential, resulting in the decreased amplitude and the shorter duration of waves within our patient. In a compensatory mechanism, more motor unit action potentials are generated, resulting in a polyphasic pattern, as seen here with many waves in a short period of time. These results are fairly typical of myopathy. However, this is our patient at rest, when we would expect to see no activity. Instead, we see waning myotonic discharges due to early recruitment. Myopathy damages the sarcolemma surrounding the muscle cells. This inhibits or decreases the functionality of the sodium-potassium pump. This elevates the membrane potential within the cell, causing a constant state of depolarization and sporadic activity. This membrane irritability associated with myopathy is specific for only a few types. These EMG results, along with creatine kinase levels beyond what we would expect for a motor neuron disorder, allow us to eliminate poliomyelitis, West Nile virus, and other disease processes that affect the motor neuron. Duchenne muscular dystrophy, Becker's muscular dystrophy, along with other congenital myopathies, are inherited genetic defects which we would expect to see symptoms over a longer period of time. The late age of our patient and the acute onset of his symptoms makes these unlikely. Glycogen, lipid, and mitochondrial disorders are metabolic myopathies characterized by subacute progression and many recurrent symptoms, not fitting the acute isolated incident within our patient. Inclusion body myositis, dermatomyositis, and polymyositis can all be characterized by proximal and distal muscle weakness. Inclusion body myositis typically develops over the course of months to years. Dermatomyositis can be characterized by a rash on the eyelids as well as the skin overlying joints. Polymyositis has many associated symptoms, including a shortness of breath, arrhythmias, difficulty swallowing, weakness performing specific activities, among others. Toxic myopathies can be statin-induced, glucocorticoid-induced, as well as induced by beta blockers. Inflammatory myopathy would be consistent with our elevated creatine kinase levels, as well as the EMG results. It would also make sense of the elevated anti-Rho, as there has been a known association with collagen vascular disease. However, this is typically subacute in progression with chronic symptoms. It is important to note that without a muscle biopsy, we can either confirm or rule out inflammatory myopathy. However, our leading differential diagnosis is toxic myopathy induced by statins. Simvastatin is a lipophilic drug that inhibits the mevalonate pathway at the HMG-CoA reductase step. This results in a decreased net biosynthesis of cholesterol and is therefore an effective treatment for hyperlipidemia. Simvastatin is metabolized using the cytochrome P450 pathway. Amlodipine, doxycycline, and finasteride, all of which our patient was taking concurrently, use the same cytochrome P450 pathway to be metabolized. This results in a slowed metabolism of simvastatin. Gemfibrozil, a fibric acid derivative taken to decrease triglyceride levels within our patient, has also been known to disrupt metabolism of simvastatin by interfering with its hepatic uptake. Together, these mechanisms result in a buildup of simvastatin within the blood plasma, allowing it to exert its toxic effects within our patient. We performed a muscle biopsy taken from the right quadricep of our patient to confirm myopathy as well as determine the subtype. No inflammatory cells were present, which rules out inflammatory myopathy. Only signs of acute muscle cell damage and death were noted. Panel A was taken from our patient. Panel B was taken from a control. Both are frozen cross-sections stained with hematoxylin and eosin. If we compare our patient's A compared to B, we can see an increased variation of muscle cell diameter compared to B. We can also see a loss of sarcolemma nuclei in A compared to B. These results indicate myofibronecrosis. If we look at panel C taken from our patient, staining for membrane attack complex, the brown discoloration is indicative of necrotic fibers. These results confirm a final diagnosis of statin-induced necrotizing non-inflammatory myopathy. With patient management, emerging research, and ethical considerations, I give you student Dr. Dexter Dale.
Thank you, student Dr. Damshin. I'm student Dr. Dexter Dale. I'm going to be discussing the management, emerging research, and ethical considerations regarding our case. The diagnosis reached was necrotizing non-inflammatory myopathy. This was likely caused by his medications or a group of medications interacting with one another. To treat our patient, they took him off of the statins. When his creatine kinase levels returned to normal, they prescribed him physical therapy to regain his muscle strength. When reviewing this case, it is important to consider additional options and possibilities for treatment. Drug interactions should always be assessed for potential contraindications. Additionally, OMT should also be assessed. However, research on this specific subject was not readily available, and we have deemed it inconclusive. Finally, the risk factors of the patient should also be assessed. This is a chart detailing several risk factors that increase the risk of statin-induced myotoxicity. Our patient exhibited 5 of these symptoms. He was on a high dose of simvastatin at 40 milligrams. Simvastatin is a lipophilic statin. As my colleague, student Dr. Jordan Damshin, discussed earlier, our patient was also taking amlodipine, doxycycline, finasteride with his simvastatin, and those all interacted with each other. Our patient also had several comorbidities. He had hypothyroidism, diabetes, and was obese. Our patient was also 79 years of age. Regarding the outcome of the patient, full muscle strength did return. His creatine kinase levels returned to normal. However, our patient did experience progression to end-stage renal disease. We theorize that this is secondary to his myotoxicity in addition to his already present chronic renal disease. In addition, the patient was placed on dialysis on day 11 in the hospital. There's some relevant research regarding statin-induced myotoxicity. We've specifically highlighted 4 studies here. The first study highlighted is regarding vitamin D, and it was shown in this study that participants with decreased vitamin D levels were more likely to have myalgia than those with increased vitamin D levels. The second study listed is regarding genetics, and it was stated that polymorphisms in the cytochrome P450 enzymes were a cause of myotoxicity. The second study listed under genetics also states that mutations in the genes that encode the transport of hepatocytes would increase plasma concentration of statins and therefore lead to myotoxicity as well. The final study listed here is regarding ethnicity and statin myotoxicity. And in this study, it was shown that various races are more susceptible to statin-related myotoxicity. In particular, in this study, it was shown that Asians, Black Africans, and Black Caribbeans were the most susceptible. This is possibly due to genetic variability in drug metabolizing enzymes. We came across several ethical considerations regarding this case. First and foremost, our patient spoke primarily Spanish and very little English. Additionally, it was stated that he was illiterate, and we're not sure if this was solely to English or both to English and Spanish. Patient communication is key in any healthcare setting. And this is key so that the patient can have full understanding and autonomy when making decisions. To do this, we would provide the patient with a third-party certified translator to interact in all patient-doctor interactions. Additionally, we would provide resources in English and Spanish via databases such as UpToDate or Clinical Key. It is not exactly clear why our patient was non-adherent, but by providing him with the options listed above, we'd like to think that the probability of his non-adherence would likely be decreased. Another ethical consideration is regarding polypharmacy. By definition, polypharmacy is the administration of more medications than are clinically indicated. It is highly prevalent in the elderly population, those over 65 years of age. Our patient also had several potential contraindications. The FDA recommends amlodipine with only 20 milligrams of simvastatin. Our patient was taking 40 milligrams. Additionally, gemfibrozil and simvastatin are contraindications of one another, yet our patient was being prescribed both. The patient was also being treated for iron-deficient anemia and was taking iron supplements. We're not exactly sure why this was, because the patient's anemia was likely being caused by his chronic renal disease. Additionally, we're not sure how many healthcare providers he had, but given his many conditions, he likely had several. It's also not clear what sort of communication occurred between the providers, but multiple providers not communicating with one another could also be a cause of the polypharmacy phenomenon. Several risk factors have already been discussed, and they should always be taken into account when prescribing medications. The final ethical consideration we have here is regarding the patient's advanced age. Our patient was 79 years of age and had several chronic issues upon admittance. Many invasive and expensive procedures were performed that ultimately did not lead to our final diagnosis. We questioned how many of these tests were actually needed, which leads us to the question, just because you can perform a test, should you? Finally, considering the patient's age, we always need to consider quality of life and patient autonomy when making healthcare decisions. This concludes our examination of Case 7, statin-induced necrotized myopathy. We'd like to thank the following faculty for their assistance, and we would also like to open the floor up for any questions. Thank you.
I love the way you guys went through that differential diagnosis. That was great. You obviously put a lot of hard work into that. Let's do a couple of questions real quick that were submitted during your presentation. Start over here.
Okay, the question is there a relationship between vitamin D deficiency and statin myopathy? And so vitamin D is synthesized from cholesterol, and with statins, we would expect to see a decrease in cholesterol. So what we would expect to find would be also a decrease in vitamin D, as well as cholesterol. Additionally, there has been studies, although the mechanism isn't explicitly stated or known, that a decrease in vitamin D deficiency would actually lead to greater chance of myalgia and myopathies.
I think you indicated that with your emerging research. That was a good job. Anything else here?
The question was, what does lipophilic statin mean? And that just means that it's easily able to cross the membrane of the cell. And with these, you'll see that there'll be a higher toxicity to the muscles. Then I had another one. Besides cardiac ischemia, I can't say it, ischemia, what else will cause elevated CKMB levels? And this could be due to the skeletal muscle breakdown like we showed, but also carbon monoxide poisoning, crush injuries, a pulmonary embolism, hypothyroidism, and then a muscular dystrophy.
Okay, so there was a question on what is claudication and what causes it. Claudication is a reproducible discomfort in the extremities, especially the lower extremities, that's relieved with rest, but is often worsened with activity. And this is typically due to decreased blood flow in the lower extremity, especially due to peripheral arterial disease. And in our patient, this increased over time.
Okay, the question was, what is the significance of renal tubular cells found in the patient's urinalysis? Renal tubular cells are associated with renal tubular acidosis in chronic kidney disease, and also from kidney damage from the proteins released in rhabdomyolysis, namely myoglobin and its metabolites, and under oxidative stress to the renal tubules.
Actually, you guys have a mic over there, so let me.
Okay, our next question was, simvastatin causes muscle weakness, and could this be a contributing factor? And yes, it ultimately was the cause for our myopathy in our patients. And they also asked for the side effects of statins, and that can include muscle pain or damage, liver damage, digestive issues, rash or flushing, and increased blood sugar and neurological side effects.
My question, what is another reason you would hold lisinopril? And our patient was hyperkalemic, and lisinopril has a chance to cause hyperkalemia. So,
is that it for questions?
We got one more.
One more, okay.
The last question was, why was an EKG performed? And what EKG findings would be present in an elevated potassium level? It's performed to assess for an abnormal heart rhythm. With increased extracellular potassium, you're going to reduce and depress the SA and the AV node, which would lead to bradycardia and eventually cardiac arrest.
And I think they wanted to know about the EKG findings associated with hyperkalemia. Did you look that up?
Just depression and slowing. Of the,
I didn't want to peak your T waves there, but okay. All right, so here's kind of the deal. You guys in the group preceding you are first years, but during your presentations, you're supposed to perform at a first-year residence level. You guys clearly did that, so congratulations. And I think everybody, let's stand up and give both groups a standing ovation. Well done, and good job, guys.